Thank you. Thank you for the opportunity to speak today. I am Jaime Raymond. I'm the lead epidemiologist with the National ALS Registry. That's with the Centers for Disease Control in the United States. Today I'm going to be talking about our registry data and a recent study that we published on the racial disparities in the diagnosis as well as the prognosis of ALS. I have no disclosures. So I'll give a brief outline on what ALS is. I'm going to talk about the National ALS Registry and why it's important in this part. What do we currently know about ALS? And then I'm going to talk about our recent publication. So ALS, or Lou Gehrig's disease as it's called sometimes, is a progressive fatal disease that's caused by the degeneration of motor neurons. About 80% of our cases die within 2 to 5 years of their initial diagnosis. About 90% of our cases are sporadic, meaning just 10% have a familial or genetic background. The risk factors are largely unknown, especially for our sporadic cases. There's no cure. We do have 3 drugs that are currently approved in the United States that typically prolong life by about 2 to 3 months. So, in the early 2000s, there was a concerted push from ALS patients and caregivers to have an ALS registry in the United States. The public law was enacted in October of 2008. This directed CDC to create a nationwide US registry. The registry goals were to describe the incidence and prevalence of ALS in the United States. We wanted to describe the demographics of our ALS patients. And we wanted to examine the risk factors through risk factor surveys for ALS patients. 2 years after the law was enacted, we launched the National ALS Registry. Now, this act did not make ALS notifiable. So patients and caregivers, or patients and neurologists are not required to send cases to their local health departments or to CDC. And here is our website for more information. So why is the National ALS Registry important? Well, it's the first population-based ALS registry in the United States. We've been operating for just over 14 years. We do have a web portal portion, and in that, we started in 2010 with 6 risk factor surveys. We are now up to 18 risk factor surveys. So we have 115,000 completed surveys from our patients and over 20,000 patients who have voluntarily self-enrolled. We continue to seek what causes ALS through analyzing our risk factor surveys. We're looking at the causes, and we're trying to understand the incidence and prevalence as well as the mortality of ALS in the United States. So, unfortunately, we know a lot more unknowns about ALS than we know about ALS. Risk factors that we've identified in the registry as well as some of our partners. We know that white males over the age of 50 seem to have a higher rate of ALS than other demographics. Occupations. The University of Michigan has recently come out with some publications that showed that certain blue-collar occupations had a higher rate of ALS than others. Military service. We know that our veterans are about twice as likely to have ALS than our non-veterans. We published a couple years ago on leisure physical activity, and we did notice that those who exercise vigorously more than 3 times a week at younger ages were typically diagnosed at an earlier age. We've looked at smoking and drinking, as well as geography. Earlier this year, we published a prevalence report on all 50 states, and we did see a north to south gradient, with our northern states having a higher rate of ALS compared to our southern states. And then, of course, family history. So moving on, we took the survey data that we have, and we were able to look at some of the racial disparities in the diagnosis of ALS with our data. So we know that racial disparities are common and not just in ALS. This pertains not only to access to care, but to symptom onset to diagnosis, disease onset, and interventions that ALS patients receive. So we were able to analyze data from the voluntary patient portal, online surveys, for about a 10-year period. We were able to stratify race by white, black, and other races. And with that data, we've got a little over 4,000 ALS patients in our study. So the first thing we wanted to look at was age of diagnosis stratified by race. Now you can see here that for age of diagnosis, our Black patients, we had about a little over a fourth of them were our white patients, that was just under 13%. We also saw something similar with almost a fifth of our other race patients being diagnosed before age 50, whereas you can see with our white patients, it wasn't until we hit about 60 that we saw that big jump of over 38%. So next, we wanted to look at mean time from symptom onset to diagnosis, again, stratified by race. And you can see here that our Black patients had, from first sign of weakness until an ALS diagnosis, was about 24 months. For our white and other race patients, it was about 16 months. We didn't see, as far as cramps and twitches go, we didn't see much difference. We did see a difference in our problems with speech for our white patients. If they had problems with speech, they were likely to be diagnosed in a much shorter time frame than our Black and other race patients. And then with problems with bowels, our other race patients tended to be diagnosed much faster than the white and Black patients. So then we wanted to look at site of onset for our ALS patients. And we didn't see much difference, except we did see for hand or arm onset, our Black patients were over 50%. More like percentage-wise to have that onset, as opposed to our white patients at just over a third. So then other symptoms that are common after an ALS diagnosis, we wanted to look at those as well. And I know this slide has a lot of data on it, but we did notice that pneumonia was a much higher percentage in our Black patients compared to our white patients. And then we also saw a slight uptick with twitching in our other race patients compared to our white patients as well. So next we moved on to specific interventions that each of the races received. For wheelchair, our other race patients typically received wheelchairs later than the white and Black patients. For non-invasive breathing equipment, our data was small for our other race patients, but most of them received it before they even had an ALS diagnosis. And then we also noticed that our Black patients were more likely to be diagnosed or be referred to hospice sooner than the other races. So what were our findings? Well, we noticed that Black patients were more likely to be diagnosed at a younger age despite having a 2-year gap. And they were also more likely to have a higher percentage of having pneumonia. From first sign of weakness until the ALS diagnosis, it was about 24 months for our Black patients, whereas that was significantly longer compared to our white patients at 16 months and other race patients at 15.8 months. We saw diagnostic delays. White patients had a shorter diagnostic delay of just at 6.3 months, and Black patients were about 17.7 months. Other race came in at 14.8. And so racial disparities, especially in the diagnosis of ALS, continue to show diagnostic delays. Thank you.
So thank you so much for that. You've brought up a lot of really significant data. Do you have particular reasons or theories why there's such a discrepancy between diagnosis from 24 to 16 months?
So I think because our Black patients tended to be so much younger, I don't think neurologists or physicians were thinking ALS could be a possibility because they were diagnosed at a much younger age.
I think it's fascinating. I mean, really very significant. There are a lot of questions from the back.
Do you think that this would impact the ability to participate in clinical trials if their diagnosis is taking a lot or many months, I guess, more than a white patient, and the inclusion criteria in trials is?
I think it
often 2 or
could.
3 years?
We don't do clinical trials, so I don't know exactly typically what the parameters are around it. But I would guess, I've heard that there are certain time frames. And so getting an accurate and quicker diagnosis would definitely help, I think.
Do you have any comparative data for black patients from other countries, for example, in terms of the earlier age of onset in your study population in the U.S.?
That would be interesting. We have not, all of our data is from the United States, but I would be interested to look at other countries to see if their race breakdown is similar, or as far as age of diagnosis. Absolutely.
Kathy Collett, ALS advocate from Indianapolis. When I read this paper, I was thinking, this is really interesting, but I think there are 2 ways to look at that age difference in the black cohort. Mm-hmm. And one is, are they younger people getting ALS, or are the patients we're missing the oldies? Because you're missing, you don't have a representative complete picture there.
Correct, yes. This is 100% voluntary, yes. So our cohort is typically in the web portal a little bit younger than probably the general population in ALS. So yes, that is definitely possible.
I think that's possible. Then another thing that kind of followed my thinking on that, and I would be very interested if anybody can do a study on this sometime, be very interesting, I think, to look at electronic health records and look at people who may have died before they got an ALS diagnosis. Because I think in that older group that may be at play. And I think that to look at the telltale signs of ALS in people who were never diagnosed and died could be interesting. Thank you.
Hi, thank you so much. Peggy Allred from Novartis. Really interesting work. And sort of keying on your comment, how much of the disparity do you think might be due to an accessibility issue for these online surveys, especially potentially in this older population, but really in the non-white population altogether, their access to the internet, their comfortability with entering these types of data, and how much that contributed to the numbers that we see?
Yes, it was definitely a limitation. You do have to have access to a computer in order to take these surveys, and it is voluntary. So there's no compensation or anything. So yes, we do know that that is a limitation of our data. We did try and use as many years as we could. Like I said, in 2010, the first 6 surveys came out. This clinical onset survey didn't come out until 2013. So we really did try and use as many years as we could to try and get, but absolutely, it's definitely a limitation of our data.
Did I see? There's another question here.
Hi, thank you so much for the talk. I'm Isaac from Edinburgh. Just wanted to know that now that you have this data, what are your next steps, knowing that there is health inequalities in the States for black male?
Yeah, that's a great question. We worked with a neurologist out of VCU on this manuscript because she was kind of seeing the same thing in her neck of the woods. So just trying to get it out there that ALS affects everybody. There is not one demographic that it does not impact. So knowing that hopefully will be in neurologists' heads, that even though if it's a younger person or a minority, that ALS is still a possibility.
I'm in the middle. Sunny from Texas with her ALS story. And just a comment from personal use, I think what you may be, not you, but the study may be missing is that your website is awful and the app isn't user-friendly and it's not eye gaze technology friendly. So even being almost 10 years in, I willingly opted not to participate because it's not configured to use on my phone. So if it's not easy or it doesn't come with a beer, I'm not doing it.
So I will say, I don't know if it's good or bad. Our website has changed significantly, like I think this week or last week. It is in line with what CDC does. So we're not we're limited in how we can display the data. We are trying to make the surveys more user-friendly on an app, but we have to be careful because when people register, they're registering their names, and that goes in a secure database that cannot be, you can't use an app to do that. So we are trying to make it more user-friendly and to make it look visually appealing. But it takes time because, like we said, we have 18 surveys. But yes, check out the new website. Let us know if you like it better or not. We can only change so much of it because we're kind of constricted. But check it out and let us know.
Oh, there's another question there.
Sonny, not an inducement, but I'm happy to sit alongside you, and you might have some sips of my beer if you finish this. So thank you, Janie, for presenting, and I'm Lauren with Les Turner. We are a contracted provider. And, you know, taking a look at the needs and as reaching out into the community is something that we have to do better, and we take ownership of that at Les Turner. But one of the things that I think I wanted this global audience to know is there was a National Academy of Science, Engineering, and Medicine report that very clearly used some of the data that Janie presented and outlined ways for us to meet the challenge of health equity. And so we all have a responsibility in the States and across the globe, because I keep thinking about the health disparities across the globe, and then I also think about the health disparities in our neighborhoods. So thank you for presenting this data today, and I look forward to talking more with our colleagues about what are you doing. So I want to learn more from everyone. So I'll buy you a beer too if you have a good story to tell.
Thank you. I think that's a lot of questions. Is that all the questions now? Lovely. Well, thank you, Catherine, for your presentation.